My story started and in Washington Heights. I actually came to the United States when I was 5 years old as an immigrant, not knowing the language, not knowing coming from a communist country as a refugee in Romania. And the typical immigrant story, starting in public school, kids making fun of you, wearing socks and sandals, and working through the public school system and getting into high school like your Bergen Academies at Bronx Science in the Bronx. And that's where my passion started to begin for science and biology. And then ultimately, I did volunteer work at a hospital, at Bellevue Hospital in the city. And that was a shock to see actual how people are treated, the care that they get. I worked in a genetics lab. And then I knew from that point on that this is what I wanted to be. And my father was an engineer. My mother did work in a hospital lab, but I sort of am the first person to be a physician in my family. And that was the passion. And I got into a program called the Sophie Davis program. At that time, it was novel. And all of my high school guidance counselors told me, do not go into this program. But it was an accelerated program. It was a 7-year combined bachelor's in science and medical school together. But the goal of the program was unique, and it was really quite amazing at the time if you think about it, compared to what we hear now. Certainly now you hear all about equity and the healthcare disparities that exist in this country, the biases that exist in medicine, the implicit bias and racism that existed. But back in the 1980s, there was very little conversation about that. And in this unique program of 70 kids that worked at City College and in Harlem at the time, we would go out to clinics and go to places, and we would see the disparity in healthcare, the just sheer poverty that existed, and the lack of access to care. And this was one of the first places where you realize how healthcare really needs to be accessible, available, equitable, and just for all. And that inspired me in the sense to try to create systems where people do have quality care and are accessible to it. And it was a program that the goal was to provide primary care providers that worked in underserved areas with populations that needed the help for care. And it inspired me at that point to always remember that being a physician is a privilege. It is not that people come to you and it's so great. It's the honor that you have to care for people and to care for them in a vulnerable time in their lives and be respectful of that and mindful of that. And one of the first rules that we learn isn't so much that we heal when we do things, but it's also that we harm. And one of the first rules of medicine is do no harm. But people forget that in medicine, and we get caught up in our power and our privilege. And at the end, it really is to be cautious and be humble about the experience of being a physician and caring for others in a way with compassion. So those were the sort of, I guess, core principles that Sophie Davis built in us as physicians at a young age. I remember actually doing anatomy lab, full cadaver dissection at the age of 18, coming right out of high school, which was really quite remarkable given the accelerated program and so on. But then I get to my third and fourth year rotations in hospitals. And at that point, you realize how it really wasn't this idyllic environment of caring and compassion in so many ways. And HIPAA laws didn't exist back then. We certainly didn't have electronic medical records, and there were charts. But physicians would talk about patients as really cases, not as individuals. They would talk about them in the hallway. They talk about them in the elevators. And culture of any group or society that you participate in is so important in professions, in locations and jobs. And you'll find that every place has this culture, and medicine had this culture. And it was somewhat demeaning and demoralizing. And for a time in my third year of medical school, after Sophie Davis, I went to Syracuse to SUNY Health Science Center. And at that point, I was almost thinking about really not doing medicine because I didn't know if I wanted to join these people that were somewhat mean and obnoxious and disparaging of people. So I entered this mystique of medicine and realized that there wasn't as much caring of patients. And the whole system was built around the physicians and the comfort of physicians, not the patients. And if you'll find hospitals, they're really designed for the comfort of doctors and nurses, but not the people that they actually serve. And why is that? Why are hospitals structured around this concept where you don't challenge the doctor, you don't ask questions, the doctor functions as more of a dictator than a facilitator, and you have to follow these very strict rules? In fact, the dehumanizing process of taking away your clothes and putting you in these hospital gowns is quite traumatic to patients if you've ever been a patient. And you realize that there is this culture and there is this mystique that occurs, but it doesn't have to be, and it doesn't need to be, and things will have to change for the next generation because people are demanding it, and they no longer, this model doesn't work so well. And I think the future is quite interesting. Now, what's changing? Well, healthcare is changing, and it's changing for all professions. And doctors work longer hours. We spend quite a lot more time on administrative and clerical chores. The computer that we're on right now has actually created a significant amount of burden for physicians. We have access 24/7 to our charts and our patients, but they also have access to us. And that makes it very challenging because they can look in their charts and send us questions and ask, why is my lab abnormal, and so on. And so ultimately, it has created longer working hours, and we have many pressures that hit us from whether it's insurance companies. Sometimes throughout the week, I usually get on the phone about 2-3 hours a week to argue with insurance companies to cover certain procedures that patients had. And you get on the phone with other doctors and you provide evidence and research and data to support that. That didn't happen in the old days. Government regulators dictate standard protocols that you have to follow, and that becomes quite challenging because these regulations change and they're different administrative bodies. Like, for example, you have the AMA, and then you have the American College of OBGYN, and you also have the Society of Maternal Fetal Medicine, all coming out sometimes with guidelines and regulations that sometimes conflict with each other depending on the interests of different groups. And so that presents challenges for physicians in providing clinical care for patients. And then the legal system, the system has created challenges because, as anybody knows in healthcare, when you walk into an emergency room, the doctor doesn't see you. You get your vital signs taken and about 20 tubes of blood, and multiple tests like x-rays and CT scans are done even for simple headaches. And some of that of over-medicalizing the process rather than speaking to the patients has a lot to do with the fear of litigation that some physicians practice in. And that fear and that culture of fear has created a lot of waste and excess in the system, unfortunately. And then online presence. And I know you just heard this great lecture about your online presence. And I think that's really important, particularly as you mature and you get into certain professions, that yes, it will follow you, and people can look you up, and they're physicians who can evaluate you, but they're also patients who evaluate you. And patients sometimes are unhappy with the outcomes that they had, and their evaluations may be just, and they may not be just or fair. But at the end of the day, it's really, there's no jury or trial that you have the opportunity to defend yourself, and that online evaluations can be quite harmful and hurtful to physicians, particularly whether it's our egos themselves or our jobs, and that's always quite problematic these days for doctors. How much do you answer those online responses without violating the patient's privacy, in fact? So, and it's rare that you probably should do that. And then ultimately, the greatest and most complicated issue has been the business of medicine versus the practice of medicine. The changes itself has created a model where particularly physicians' work is valued based on something called RVUs, or relative value units. And so that's based on the hours you spend, whether it's in administrative roles or in writing papers and doing research or in providing clinical care. And that clinical care becomes quantified based on the type of procedures and the value of those procedures based on what the government has established in something called CMS through Medicaid and Medicare. And that has created incentives in the wrong direction, because the value of time, what patients want most, versus the value of procedures. And most of time of physicians is actually devalued, which is what we'd love to do in general, spend time with our patients. Whereas the procedures, the technical aspect of doing what we do, is valued on these RVUs. And that has created sometimes a clash between the care we provide and the time we want to spend with our patients versus getting through the day and creating enough RVUs to be for the hospital systems that are hiring us. And then the national debate on the future of healthcare in America. A lot of physicians feel very disenfranchised from that conversation, and they feel that they didn't have much say in the changes that occurred. Limited physician input. Interestingly enough, the hospitals, the pharmaceutical companies have strong lobbying power, and the physicians are actually the weakest lobby, and that seems to affect a lot of the debate. Even though the patients would want us to be more involved, we basically are a busy lot, and we're not a very savvy group of people when it comes to the legal system and laws and how things get passed. And so the lobbying groups are weak, but the pharmaceutical companies always seem to take care of themselves, as do the hospitals in America. And that has created a lot of frustration in doctors in feeling that they are not being heard and part of the solution. But I think we can. There's a lot of opportunity for physicians to be involved, to join, to run for public office. And there's many opportunities for doctors to actually have a say in the future of healthcare in America if they wish to join the policy debate versus just complaining about it, which we're good at. So if you talk to a lot of physicians in this day and age, a lot of people seem that they're quite dissatisfied with the healthcare itself and their decision to be a physician. And that's somewhat disheartening for me, because I never felt that way. And my passion for the reasons why I did what I did never have waned, despite all of those frustrations and difficulties. And that the question you really have to ask yourself is, why are physicians so dissatisfied? And I think a lot of times what people don't realize is that they have to remember their why. A lot of people know what they do pretty well, and these are 3 circles, and the outside is your what. Your second circle is your how. You know how to do it. So a lot of people know what they do and how they do it. And so when you ask them about their job, they're going to tell you what they do or how they do it. But very few people remember their why. Why did you become a physician? Why did you do what you do? Why do you wake up every morning? What is your inner passion, and why did you do what you do? And if you can remember your why every day, if you can identify that, you will not be dissatisfied with the choice you made, and you will try to make that improve for others as well as yourself if there are problems with it. But the reality is that always remember your why. So the good old days, well, that's when you hear doctors complaining about, how bad it is now, and how the good old days where doctors were the center of attention and, where it was so great. But the good old days they weren't that good. And if we think about that, why weren't they that good? Well, medicine is a really huge, complex system. When you're making diagnoses, that's why computers have not replaced us yet. Even if you put a group of symptoms together, physicians are more likely to get it right with experience than a computer. And that's coming close, so we don't know where we'll get with AI, but certainly there is the complexity of putting together a story and making the correct diagnoses. And the paradigms are complicated, and so is the decision making at the end for treatment plans. So I think that gets complicated, and doctors oversimplified that and often jumped to conclusions in the old days. And that leap, because of the ego, often led to inconsistent quality of care. And so you had situations like when I was a student, where you'd go into indigent and poor areas that received limited quality of care, poor quality, poor machinery, poor equipment, no access to good care, whereas in other places they had sitting in their machines that were not being used by people, just in affluent areas and pure cash hospitals or cash paying places where people got high quality of care, but it was limited only to those few who were lucky enough to be able to afford that. And then you had unacceptable levels of harm. And this is actually one of the biggest problems with the old days. They weren't that good for a lot of people. And if you go to in 1999, the Institute of Medicine actually looked at the level of harm doctors do. And remember, from the beginning of my talk, I said one of our most important paradigms, or our important sort of purposes, is to do no harm first before you do good. And in the Institute of Medicine in 1999, they looked at how much harm the physician caused. And in an annual basis at that time, in 1999, approximately 98,000 people died because of physician error. 98,000 people were hurt and died because a doctor made a mistake, whether it was right on the prescription, making a wrong diagnosis, or the wrong test. And as of really 2017, unfortunately, that number has worsened, and we're up to 440,000 people dying every year, as many people almost as died from the COVID virus annually from physicians prescribing the wrong medicine, causing harm, and unfortunately not providing the utmost care possible. And that's a lot of it's because it was doctor-centered instead of a team. And team requires a lot of people to work together in a unit for one purpose. And that purpose is not to say the doctor was right. And one purpose is to say the patient got better and walked out of the hospital safely. Additionally, there was so much waste, fraud, and abuse. And with spiraling costs because of our technologies, these good old days could never be sustained. So you had this huge amount of waste in the system, higher and higher costs, and the only people that seemed to work was the good old days for the doctors. Patients didn't necessarily fare better, and the costs were exorbitant. And that's why healthcare had to have a change, and it has to change for better. So change is inevitable. And one of the things that when I teach medical students and residents, as well as other physicians, are that you really have to adapt to grow and embrace change to get ahead. Change always happens in every profession, and change can be good, and you can be part of that solution, or you could be an obstacle to that. And generally speaking, it's not helpful for anybody. And so embracing change is important. Change is inevitable. And certainly in healthcare, the goal would be that that change becomes productive and helpful, because why did we become physicians? To provide the best care possible for our patients. So embracing change to improve care, improve access to care, and improve the quality of care people get should be pretty universal concepts for every physician and healthcare provider out there.